Hey everyone, this is Sasank Med. Today I'm going to be talking about non-invasive oxygenation and ventilation. We'll be talking about the different types of oxygen delivery for patients that are admitted to the hospital. So first of all, the recommendations for supplemental oxygen therapy. The target oxygen saturation is between 91 and 96%. Recent trials have shown that there's no benefit to higher or lower targets in critical illness. There are exceptions. So if there's a lower target, SpO2 of 88 to 92%. This is if you have baseline hypercapnia or at risk for hypercapnic respiratory failure, such as COPD, obesity hyperventilation syndrome, obesity hypoventilation syndrome, obstructive sleep apnea, decreased central respiratory drive, neuromuscular respiratory disease. A higher target, so SpO2 close to 100%. This is if the patient has carbon monoxide poisoning, cluster headaches, sickle cell crisis, or pneumothorax. I'm going to be talking about the different types of oxygen delivery. The first is nasal cannula. This is the most commonly used, and the flow is between 1 to 6 liters. The FiO2 is between 24 to 44%. And to note, the FiO2 increases by 0.04 per liter. This allows the patient to eat and speak, and you can consider humidifying the air if greater than 3 liters per minute. It's not aerosolized. The oximeter, this flow is between 1 to 15 liters. The FiO2 is between 24 to 60%. To note, there's a 20 milliliter reservoir that allows for higher FiO2 compared to nasal cannula. This is not aerosolized. We have the simple face mask. In this one, the flow is between 6 to 10 liters. The FiO2 is between 40 to 60%. To note, the flow rate less than 6 liters per minute leads to rebreathing of CO2, and it's not aerosolized. Then we have the face tent. This is the shovel mask. The flow is 10 to 15 liters. The FiO2 is between 28 to 100%. To note, this is for patients who have claustrophobia, and the FiO2 is variable. It's not specifically for patients with claustrophobia, but it is less claustrophobic, and the FiO2 is variable as there's lots of leakage due to the lack of nose seal. You should use this if their patient has stable oxygen needs. Not good for high FiO2 delivery. This offers humidification without a mask. It is aerosolized if it's humidified. We have the non-rebreather mask. This flow rate is between 10 to 15 liters. The FiO2 is between 60 to 90%. We consider first for acute hypoxemia as it's easily accessible. And you can increase the FiO2 with tachypnea and increased ventilation due to entrapment. You can titrate the flow to avoid reservoir bag collapse on inspiration, and it's not aerosolized. Then we have the Venturi mask. This is a variable flow rate. The FiO2 is between 24 to 60%. To note, there's color-coded adapters that determine the flow and FiO2 independent of ventilatory demand, useful for SpO2 goals, for example, COPD, not for acute respiratory distress. It is aerosolized, and if greater than 15 liters per minute or humidified. Another thing is of note that racial disparities in pulse oximeter measurement is a widely known phenomenon. Essentially, because the patients have darker skin, the pulse oximeters are not as accurate, and you should have a low threshold for ordering VBG and assisted ventilation. You should rely on clinical judgment. For example, do they have increased respiratory rate, any increased respiratory effort, any cyanosis, dyspnea, chest discomfort, or mental status changes. And then the high flow nasal cannula and non-invasive positive pressure ventilation. These are the ones that are referred to as the non-invasive positive pressure ventilation. High flow nasal cannula, so the flow is 10 to 60 liters per minute. The FiO2 is between 21 to 100%. There's positive and expiratory and positive expiratory end pressure generated with a closed mouth, and it's about 1 centimeter of water pressure for 10 liters flow. And the physiological effects is it increases the oxygen delivery of some oxygen, some positive end expiratory pressure, increases the ventilation, and there's decreased dead space during expiration. The humidification increases the mucociliary clearance of secretions. The scenarios where it's useful is acute hypoxemic respiratory failure. There's actually mixed evidence in non-hypercapnic respiratory failure. May decrease intubation, but no change in mortality or length of stay versus standard O2 therapy. You can consider high flow nasal cannula if they have interstitial lung disease, ARDS physiology, and also maybe non-inferior to BiPAP in pneumonia. Can be used as rescue in asthma or in patients that can't tolerate BiPAP to help with dead space washout and intubation evaluation. Then we have non-invasive positive pressure ventilation such as CPAP or BiPAP. So CPAP basically is a constant level of positive pressure and targets oxygenation. BiPAP provides positive inspiratory pressure above PEEP with each patient triggered breath, can target ventilation and oxygenation. So physiological effects of BiPAP and CPAP is oxygenation decreases atelectasis, decreases upper airway obstruction, decreases work of breathing and oxygen consumption. Ventilation increases the tidal volume and minute ventilation via IPAP. And other effects is that it decreases the venous return, decreasing the left ventricular and right ventricular preload, decreases the left ventricular afterload. So the scenarios where this is useful is acute hypoxemic respiratory failure. An IPPV may decrease the mortality and decrease intubation. You can also consider if significant hypercapnia such as obesity, hyperventilation syndrome, neuromuscular failure such as ALS and myasthenia gravis. The caveats is if PaO2 or FiO2 ratio is less than 150, this increases the death versus upfront intubation. And if the tidal volume is greater than 9 to 9.5 cc per kg per over ideal body weight, this increases death, increases intubation. So what is this saying? Essentially, if you're using NIPPV, make sure that this does not delay eventual intubation. If you find the patient that intubation is clinically indicated, you go straight to intubation. So other scenarios where it's useful is acute COPD exacerbation with respiratory acidosis. There's a strong indication for BiPAP to offload respiratory muscles, counteract dynamic hyperinflation, increase ventilation and decrease mortality, decrease intubation and decrease length of stay. Asthma can be treated similarly, but there's less evidence to support the use of NIPPV. Acute cardiogenic pulmonary edema, NIPPV decreases intubation, decreases in hospital mortality by decreasing work of breathing, increases the functional residual capacity, decreases the left ventricular, right ventricular preload, decreases left ventricular afterload. And then post-extubation, extubation to NIPPV or high flow nasal cannula decreases the reintubation risk and post-extubation respiratory failure in increased risk patients, such as those with COPD and obesity. Contraindications to NIPPV, again, as I mentioned previously, the risk of delay. So can increase the latency between intubation. So make sure if they're clinically indicated, you go straight to intubation. And risk of aspiration due to the gastric insufflation cannot clear the secretions. If the patient has altered mental status, so if the patient cannot remove the mask, and risk of injury can cause pneumothorax, and recent esophageal anastomosis or tear, or cannot tolerate decreased preload from decreased venous return, or recent facial trauma and surgery. And monitoring for and preventing failure. So the risk of failure varies based on the cause. 15 to 20% are COPD exacerbations, 40 to 60% are acute hypoxemic respiratory failure, and increases with severity of respiratory failure. The ROX index is a tool for prediction of high flow nasal cannula failure and monitoring for need for intubation in patients with pneumonia. The HACOR score is a tool for prediction of NIPPV failure and need for intubation. So make sure you do those if you're confused between intubation and BiPAP or high flow nasal cannula. The sedation used for NIPPV is IV Precedex, Haldol, Zyprexa without suppressing the respiratory drive. And then BiPAP and high flow nasal cannula on the floor. Make sure you talk to nursing and RT prior to use, and trial BiPAP and high flow nasal cannula for 2 to 3 hours and assess the response. Consider ABG, VBG to assess oxygenation and ventilation. If no improvement, discuss escalation of care to ICU. Remember that BiPAP and high flow nasal cannula must not delay an indicated intubation.